Welcome, everyone. Welcome, and thank you for joining the American Diabetes Research Association week. This week is dedicated by the American Diabetes Association, ADA, toward outstanding research and outstanding researchers who are illuminating background on diabetes, diabetes access to care, innovation, and of course, issues that impede or accelerate the care of people with diabetes. We have an exceptional speaker with us today, Dr. Yele Aluko, the Chief Medical Officer in North America of EY. EY is also best known as Ernst & Young. And so we have someone who is really an outstanding thought leader who is the director of the EY Center for Health Equity. Dr. Aluko guides strategy, solutions, competency building for health sector organizations and leaders seeking to achieve health equity. This has become, particularly on the heels of COVID, a critical conversation. I had the honor of meeting Dr. Aluko some years ago in conversation with the pharmacy community, and I can attest to the fact that he is really one of our nation's top thought leaders in the aspect of access to care and health equity. I just want to say that prior to Dr. Aluko joining EY in 2016, I think it was, Yele, you have already dedicated at that point 25 years to clinical practice in cardiovascular medicine, interventional cardiology. I believe that you also served as a sort of chief guide to a 15-site healthcare system that gave you, I think, unique understanding in terms of the fragmented health ecosystem in the United States and how do we deal with this. You have an extensive academic background. I know that you completed your MBA from Wake Forest University in business, that you've had extraordinary training in interventional cardiology from the University of Massachusetts, the medical center there. You did a training also at Cornell University. You also trained at Columbia University, and you received your initial medical degree in Nigeria before coming to the United States and blessing us with your medical expertise and passion. I know that you serve on a number of key advisory boards, including the Harvard Business Review, the Honeywell Healthcare Solutions Team, Children's National Hospital. You are also a co-chair, and I was privileged to serve with you as a co-chair on the International Well-Building Institute, the Health Equity Committee, and obviously in your role of EY, you're working with corporations and NGOs throughout the United States. I want to welcome you, Dr. Aluko, to this conversation, which is being recorded, and please share with us your perspectives of health equity and diabetes. We thank you very much.
Well, thank you, Gil, for that very generous introduction and for the opportunity to talk to you today and the audience. And I also want to amplify your welcome to our audience here today. I've been asked to talk about health disparities and the tipping point for diabetes. And I'm somewhat curious as to the verbiage and the tipping point for diabetes, because the history of that connotation of tipping point actually goes back to the 1950s. And it was coined most commonly in terms of a tipping point for what was described as the white flight. When a certain percentage of Black residents in a community led to the majority community of white residents to leave those communities in urban areas and go to the suburbs. So the tipping point somewhat connotes a point of no return. And I think it is apropos in the context of diabetes disparities specifically, and health disparities in general, to understand, are we at that point of no return with the ongoing increasing levels of prevalence, type 2 diabetes in general amongst minorities, as well as broader disparities in general? So I'd like to speak today about the upstream drivers, the downstream drivers, the manifestations downstream that result in health disparities. So what exactly do we mean when we talk about health equity? I'd like to first of all make it clear that health equity is an aspirational connotation. It doesn't exist, and it has never existed. It's only can happen when every person has the opportunity to attain their full health potential, and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. But we need to understand that achieving health equity occurs when health disparity gaps are closed. And it may be somewhat self-serving to consider the notion of health equity as self-serving in a society that was perpetually designed to be separate and unequal. Indeed, some people will say that achieving health equity is a hallucination. Health equity will become a reality if that hallucination is moved towards a vision, and if that vision is strategically executed to drive gap closure downstream. The history of health disparities needs to be well understood within the context of the birthing of America and the history of racism, to speak, in American medicine. This goes all the way back centuries ago to the era of unconscionable experiments performed on enslaved people. And indeed, the realization that the culture of the times enabled the medical profession itself to intensify efforts to justify slavery scientifically. Indeed, the medical profession did embrace and further entrench a segregated health system, a separate and unequal system. And the Jim Crow laws that resulted in segregated white and blacks, dating all the way back to 1880s, in the health industry actually continued to the 1960s. In 1910, Abraham Flexner was commissioned by the American Medical Association to do an assessment of all Canadian and American hospitals. Wanting to understand and to try to standardize the quality of medical training in America. But also implicit in this ask was to control the pipeline of medical providers. So Abraham Flexner in 1910 released his report, and he recommended that all Black medical schools be closed. At the time, there were 7. All Black medical schools be closed, with the exception of Howard Medical School and Meharry Medical School. He deemed that all Black medical schools were substandard, and that indeed that Black doctors were not well trained. This was a significant indictment to Black hospitals and Black healthcare. He also went further to state that Black physicians were not qualified to perform surgery, and they were not qualified to participate in clinical research. Now, this was a damning indictment to the Black medical profession. But what it did was actually create a negative perception amongst white Americans and also Black Americans to the quality of Black healthcare. And that bias has persisted till today. I mentioned earlier that there was the issue of segregated hospitals that up until 1964 persisted in America, and that's not that long ago. In 1964, when the Civil Rights Act, Civil Rights Act number 5 was passed, it took 1 year before Surgeon General Stewart, 1966, sent a letter to all American hospitals informing them that if they did not desegregate, that they would no longer be the recipient of federal funds. So in 1966, literally within a week, our hospitals began to desegregate. So it's important to understand from whence we have come as we seek to develop strategies as to how we can move forward. Now, this is not an indictment of anybody who is practicing medicine or is making laws today. We have to remember that one of America's most shining moments was the desegregation of our hospitals. And this was done in collaboration with Black and white activists. This was pushed over the line mainly by white legislators who had the moral fiber at the time was seeking health equity for all back in the 1960s. So with that in mind, it shouldn't be surprising to anybody that racial inequality across national systems permeates every facet of our lives and our societies, be it in health, in education, criminal justice, and in economics. Our health disparities continue to exist across America, with the greatest disparities in the southern part of the nation and among Black and Hispanic populations. Black Americans are more likely to live in neighborhoods with limited healthcare services. Hispanic populations are more likely to be uninsured. There's a 4 to 7 to 5 year life expectancy gap among Black people as compared to whites. And 50% of Hispanic adults find difficulties in finding affordable healthcare, and by extension, lack access to healthcare services. As a consequence, socioeconomic status is a consequence of lack of health coverage. Black, Indigenous people of color have skipped or delayed medical care simply for cost reasons. I want to take us down memory lane to a time when housing discrimination demonstrated a prime example of the historical inequity manifesting today as present-day barriers to opportunity and progress for Black and Brown people. Many will remember, some may not, that redlining was the discriminatory mortgage appraisal practice used by the federal government after the Great Depression. By drawing lines around Black and immigrant areas that denoted them as risky sites for mortgages. And you see this map of Richmond on the left. Now, neighborhoods were classified from A, or best, to D, for hazardous. And Ds were colored in red and the As were colored in green. Now, while redlining was banned 50 years ago, its legacy continues to adversely impact minority communities today. And why do I say that? It is because you fast forward these geographic footprints to present times, we have a consistent observation that there has been a lack of investments in these historically redlined communities, a lack of investment in community resources that provide access to education, that provide access to healthy eating, that provide green areas and opportunities for physical activity. And therefore, the historical relics of redlining have created communities that have adverse social determinants of health. And we may say that this is all historical, but there is evidence, present day, of similar situations. A 2022 review of studies examined bias in healthcare, and it found that higher levels of provider implicit bias was associated with racial disparities in treatment, its recommendations, lower expectations of patient-provider bonding and cultural competency, and lower provider empathy towards Black patients. A 2022 study of diabetes treatment uptake by race and ethnicity also showed that Black adults with diabetes were less likely than white adults to use or to have access to one of the three new medication classes for both subcutaneous as well as oral diabetic treatment. And Latin and Hispanic adults had use rates that also lagged behind those of white patients. This is not all about diabetes. Diabetes disparity and bias is a manifestation of the societal larger ecosystem. A 2021 review of studies examining disparities in pain management also demonstrated that a patient's social demographic profile impacted the treatment of their chronic pain, with Black race patients being significantly associated with an underestimation of pain by healthcare providers. So we're here to talk about diabetes. So what is diabetes? Essentially, it is a chronic health condition that affects how the body regulates blood sugar levels. And we all know that blood sugar is essential for energy. There are three main types of diabetes, as well as one pre-diabetic health condition, which you see on the far left. And then you have type 1 diabetes, then you have type 2 diabetes, and you have also gestational diabetes. 1 in 3 adults are pre-diabetic. 1.6 million Americans, both adults and children, have type 1 diabetes, and that reflects 5 to 10% of the diabetic population. Far more people have type 2 diabetes, 21 million Americans, adults, which represents 90 to 95% of the diabetic population. And 2 to 10% of pregnant women will get gestational diabetes. And these conditions are associated with certain risk factors and comorbidities: unhealthy diet, physical inactivity, as risk factors, alcohol consumption and smoking, pre-existing conditions and family history. And there are comorbidities, including hypertension, hyperlipidemia, as well as obesity. There are compounding and intersecting individual and social factors that drive disparities in diabetes prevalence before we even get to its treatment. Diabetes is the 8th leading killer of Americans as of 2021. And it results in more than 70,000 deaths annually, and it costs up to $327 billion in the context of both direct and indirect costs to the US health system. It's more prevalent among American Indians and Black Americans. Black and Hispanic populations face 50% higher risk of diabetes due to the disproportionate burden of adverse social determinant risk factors, what we call the social vulnerability health risk. Individuals earning less than $80,000 a year are up to 3 times at a higher risk of developing diabetes. If you go to the right-hand side of this slide, we look at the prevalence of type 1 and type 2 diabetes. On the left side of this graph, we see the prevalence of type 1 diabetes for those under 19 years of age between the years of 2003 and 2018. And we see that the prevalence is highest amongst Caucasian Americans for type 1 diabetes. We go to the right, the same time frame. We see a significant uptick in type 2 diabetes prevalence in Black Americans. And at the bottom, we see the prevalence in type 2 diabetes for Caucasian Americans, and it stays steady. And in between, you have profiles for Hispanic Americans, Asian Americans, as well as Native American and Alaskan Indians. So obesity and diabetes are interrelated chronic conditions that overlap in risk factors interventions in the context of impacting adversely affected populations. We see here that the leading risk factor for type 2 diabetes is obesity. And the two chronic diseases are actually driven by similar social determinant risk factors. Diabetes and obesity are both on the rise among young adults over 20 years of age. And Black and Hispanic populations are disproportionately affected by both obesity and diabetes. Similar lifestyle changes are recommended as prevention and treatment. GLP-1 agonists are now seen as an emerging treatment modality for both conditions. 30 to 35% of new diabetes cases in America are linked to diabetes, to obesity. Now, I spoke about bias, and bias manifests in many ways beyond racial bias. Now, diabetes patients face pervasive stigma across healthcare and society at large. And this is because this bias perpetuates beliefs that type 2 diabetes in particular, and remember that type 2 diabetes is often associated with significantly excess weight, that beliefs that type 2 diabetes is associated with individual decision-making and lack of discipline. More than 80% of those with type 1 or type 2 diabetes reported experiencing stigma, suggesting that having diabetes was a personal failure and a lack of personal responsibility and discipline. More than 1 in 2 adults, similarly with type 2 diabetes, experience judgment for their dietary choices. In an absence of understanding the accessibility of more healthy and responsible dietary choices. Almost 45% of diabetic adults feel judged by healthcare providers for their weight. And overweight diabetics have internalized weight stigma and have associated this with less self-management as a consequence and lower opportunity for self-efficacy. In 2017, the US study demonstrated that providers in a 2017 US study described individual patient responsibility, patient readiness, and motivation to change as unmet factors for diabetes prevention and treatment adherence. So you get the drift here that a lot of the responsibility for diabetes, the industry has developed a bias towards the condition, the disease condition and the impacted people as it being a personal failure. But we need to know that while personal decision-making is important, some people may be born into societies and communities that expose them to structural inequities driven by systemic biases, that are perpetuated by political determinants, such as judicial orders, federal laws, state laws, and executive orders that could be driven by classism, sexism, racism. And it is these structural inequities that drive the social determinants of health. Absent of health coverage, absent of access to medications, absent of access to healthy foods, and lack of access to employment that provides health insurance can disadvantage communities, and in particular, can propagate risk factors for diabetes. All of this happening before impacted individuals engage the health ecosystem for management, and within the bricks and mortars of doctors' offices, diagnostic centers, urgent care centers, and hospitals, the issue of stigma, the issue of cultural competency, the issue of dissatisfied patient experiences due to bias, and disparate quality of care due to unequal treatment, all compound to drive what we see on the far right, avoidable differences in health outcomes caused by unequal structural and social factors. These social determinants of health shape individual and population level risk for type 2 diabetes. And these upstream socioeconomic and political drivers increase risk for prediabetes and type 2 diabetes for vulnerable demographic groups. These SDOHs, as mentioned, include economic stability, neighborhood and the built environment, safe environments that provide for good housing, access to easy transportation, access to grocery stores and to green spaces, social and community context that is absent of discrimination and prejudice, community safety, healthcare access and quality, and adverse opportunities in these domains result in inequitable socioeconomic factors and vulnerable populations that face disproportionate rates and burden of type 2 diabetes. They're more likely to be undiagnosed for diabetes due to lack of insurance, and by extension, untreated, are more likely to reduce or delay medication due to costs, are more likely to face discrimination and systemic disenfranchisement. Now, it's interesting to note that the overall rate of diabetes-related complications have declined since 1990. However, racial and ethnic disparities in diabetes treatment and outcomes have remained and to some degree have increased. Compared to white diabetics, Black and Hispanic adults with diabetes are less likely to receive recommended preventive care, such as screening for hemoglobin A1C, annual cholesterol screening, and annual retinal exams to assess the presence or absence of diabetic retinopathy. They also face higher rates of diabetes-related complications, such as protein in the urine, high albumin levels in the urine. That's an indicator of impending significant kidney disease and damage. Higher rates of diabetic retinopathy due to blood vessel damage and poor overall blood sugar level control. If you move to the right-hand side of this slide, see that the prevalence of diabetic retinopathy is significantly higher in the Black population as compared to the white population. And the incidence of lower limb amputation, patients per 1,000 person years, is significantly higher in Hispanic and Black populations. And the incidence of end-stage diabetic kidney disease resulting in the need for kidney dialysis due to irreversible kidney damage is significantly higher in Black patients. Now, more than half of Americans are blessed to be covered by employer-sponsored insurance. And employer health plan formularies go a long way in shaping access to diabetes and obesity medications. About 55% of Americans are covered by employer-sponsored insurance, ESI. And we see that Medicare and Medicaid coverage is between 18, 20, almost 20%, 19%. And the veterans insurance covers about 10%, and about less than 4%, 3.5% of people are self-pay. Now, GLP-1 coverage and the position of employers. Employers cover 75% of employers, as of today, cover GLP-1s for diabetes treatment. And this is data from this year. 43% of employers cover GLP-1s for weight loss as of this year. In regards to the barriers for GLP-1 coverage, almost 50% of employers cited lack of trusted information, while 38% of employers cited cost challenges. In regards to desirability of coverage, 80% of employers agree that GLP-1 coverage will benefit employees in the long term and are willing to invest in the long-term value for the resiliency of the human capital of their workers and, by extension, of the business. And 75% of employers covering GLP-1s for weight loss report doing so due to higher employee satisfaction, and it's done to provide value to the workforce, understanding the importance of the human capital that was so clearly demonstrated during COVID-19. These drugs are expensive, and you can see here, it's a smattering of list prices of GLP-1 class medications. And they're 4 to 11 times more expensive in America compared to international markets, ranging from the mid 800s to the mid 1300s of dollars. Absent of health coverage, it is literally impossible to get access to these medications. Now, Medicaid, I was speaking about commercial just now. Now, Medicaid and Medicare coverage of GLP-1s for weight loss is complicated by existing statutes. Let's take a look at where Medicaid and Medicare stand. So for diabetes, Medicaid covers treatment of type 2 diabetes. Now, for weight loss, coverage policies vary by state for Medicaid. And currently, coverage for GLP-1s for weight loss drugs is very limited to less than 10 states and is subject to various restrictions. For Medicare, diabetes is covered under Medicare Part D for type 2 diabetes, and current law prohibits coverage by Medicare of drugs used for weight loss. Glad to say that new CMS guidance following the FDA's approval of GLP-1s as an anti-obesity medication is paving the way for coverage. And this policy landscape continues to evolve. Now, in 2002, the US Congress commissioned the Institute of Medicine to evaluate whether disparities in the healthcare delivered to racial and ethnic minorities were real or not. And after scouring through more than 500 peer-reviewed journals and scientific publications, they delivered a verdict that disparities in the healthcare delivered to racial and ethnic minorities are real, and they are associated with worse outcomes in many cases, which is unacceptable. That was in 2002, some 22 years ago. And subsequent to that, the Institute of Medicine published very high-level recommendations in regards to how to proceed methodically and strategically to begin to close gaps in health disparities across pretty much multiple domains of clinical conditions. And at that time, our understanding had evolved from when no data on health disparities was interpreted as no problem to what was substantiated very scientifically and validated credibly with current compelling evidence confirming the persistence of glaring health disparities over the past 150 years of organized medicine. Now, what's happened since then? The flooring cottage industry, specialized in intellectual discussions of health disparities, has been spawned, and numerous academic publications continue to evolve. But what's also happened is a failure of the American healthcare industry to hold itself accountable for corrective action and for the systemic delivery of evidence-based medicine to all populations to achieve health equity. Biases and inequities persist in systems, in policy, and in practice across the healthcare industry. I must state that the Institute of Medicine, as its most overarching recommendation to address this issue, was the identification of systemic racism as the major driver of health disparities, and that programs and strategies and processes should be developed to address this issue. This was 22 years ago. Indeed, my team at the Center for Health Equity, we published a report just over a year ago looking at the investment in health equity initiatives since 2002 till present, and the evidence or lack thereof of gap closure. And what we found was that almost $200 billion available to us from publicly available information has been invested in health disparity initiatives since this publication. We also found that while there has been some increase in population health by way of increase in life expectancy in general, reduction in some cancer incidences, the gaps between Caucasian outcomes and minority outcomes has been left unchanged. Mild improvement in population health, but no gap closure. And the question is why? And that also begs the question as to what is the role of accountable organizations in achieving health equity in America? Organizations must adopt a strategic approach to advancing health equity. When we're talking about professional medical organizations, healthcare organizations, government and public health agencies, academic medical centers. But implicit in this is the erroneous notion that this health disparity problem is a problem that should be solved by the health provider agency. We need to understand the complexity of the health value chain and also the diabetes management value chain. It involves the interplay of diverse stakeholders, many who have misaligned incentives and agendas. So we see Health and Human Services, CDC, FDA, life sciences, pharmacies, retail pharmacies, biopharma companies, payers and providers, the funders and the deliverers of healthcare, disease associations, educational institutions. Now, accountable organizations should be positioned to adapt and to advance mutually synergistic strategies that reinforce improvement of diabetes outcomes potential for all patients. This is a societal responsibility. It is a community responsibility, an interpersonal responsibility, one to the other, and also an individual responsibility. Now, the cost of doing nothing is very high. It is unacceptably high and unsustainably high. Disparities drive unsustainable costs and inefficiencies, resulting in billions of dollars of avoidable spend. We look at care utilization and spend impact of unfavorable social determinants of health. In other words, lack of investment into society and communities that are at risk. The $52 billion excess annual healthcare spend in the US is attributable to food insecurity. $29,000 savings per covered enrollee associated with the provision of housing after accounting for the cost of housing. Look at health inequity results in demonstrable incremental costs to the health system for $50 billion of estimated annual cost of US racial and ethnic health disparities. As of 2018, $978 billion of estimated annual cost of US education-related health disparities in 2018. Health equity efforts will benefit all healthcare consumers. And I want to touch on the curb cut effect, which is a demonstration of targeted universalism, which has demonstrated that supporting the most marginalized in society benefits all in society. So the curb cut effect illustrates the outsized benefits that accrue to everyone from policies and investments designed to support the marginalized in society. It was in Seattle, I believe in the 1980s, that curb cuts in sidewalks were first engineered. And the intent was to provide access to the disabled in wheelchairs so that they could negotiate coming off street, off the sidewalk onto the street to cross streets when necessary and vice versa. Then a magnificent and unpredicted thing happened. After leveling the height of sidewalks in strategic places to create curb cuts for the disabled in wheelchairs, everybody benefited, not only those in wheelchairs. Parents pushing strollers headed straight for curb cuts, so did workers pushing heavy carts, business travelers wheeling luggage, even runners and skateboarders saw the value in curb cuts. And this is an illustration of how targeted universalism, such as the curb cut effect, benefits all if we develop strategies to optimize diabetic care in the most vulnerable populations. By extension, we will optimize diabetic care in all diabetics, in all classes, type 1, type 2, and gestational diabetes. So what will it take to achieve health equity? It's a shared societal responsibility. It's an acknowledgement of the perplexing persistence of the fundamental incongruity of the US health industry value chain and its failure to drive value for the most important stakeholder in this value chain, and that is the consumer. It will take an alignment on opportunity to systemically re-engineer business models in the health industry, to provide education, care models towards achieving health equity, delivery, and accountability. It'll take execution of health equity strategies that are held accountable for delivery, that drive cultural transformation, that enables infrastructure integration, resource deployments, and data-driven performance transparency, that is willing and humble and empathetic enough to accept the stark reality of the upstream drivers of disparities in society at large and in the health industry specifically. This will require collaboration and coordination amongst business, political, clinical, and community leaders to focus on these upstream drivers as a prerequisite to impacting the downstream consequences of inequities. It will require sustainable, long-term strategic investments in data, technology, people, and cultural transformation. It will require a hard look in the mirror about each person's individual or organizational bias within society. Disease associations have a unique role to play as leaders that engage patients, providers, and caregivers through education, advocacy, and other opportunities. And I bring you back to this value chain. And you see shaded on the right-hand side, disease associations that build health literacy, conduct advocacy, deliver services, drive accountability. You see on the left-hand side, governmental organizations. In the middle, you see life science companies, pharmacies, and so on. Now, federal agencies and other national stakeholders continue to support these important initiatives that are designed to address disparities. For example, the Centers for Disease Control's National Diabetes Prevention Program supports prevention in diabetes. 2016, the CDC launched its Do I Have Prediabetes campaign, the first national campaign to raise awareness of prediabetes. The United States Congress has increased affordability as part of the Inflation Reduction Act. Congress has capped Medicare co-pays for insulin, increasing financial access for millions of Americans to diabetes drugs. The Office of Disease Prevention and Health Promotion of HHS is focused on decreasing the burden of diabetes. Healthy People 2030 national objectives include the goal to reduce the burden of diabetes, and by so doing, improve the quality of life for all people who have or who are at risk for diabetes. And the American Medical Association, importantly, is focusing on addressing risk factors. In 2023, the AMA confirmed its recognition of obesity as a chronic disease in of itself, enabling additional support to address a major risk factor for diabetes. Now, the American Diabetes Association should be commended because the ADA is at the forefront of working to prevent diabetes and enabling access to the best possible diabetes outcomes. Does so by leveraging the ADA's Health Equity Bill of Rights, which calls for the right to access insulin and other drugs affordably, the right to healthy food, to insurance that covers diabetes management, the right not to face stigma nor discrimination, the right to avoid preventable amputations, the right to participate proportionately in clinical trials without fear of abuse, the right to stop prediabetes from becoming diabetes, the right to live in a built environment that does not increase one's risk for accumulating social health vulnerability, the right to access to the latest in medical devices, and the right to have your voice heard. The ADA has embarked on transformative change, enabling access for all Americans, assuring care beyond insulin, and dismantling barriers. So I want to close by raising a call to action that all of us as individuals and organizations should become a force multiplier of the mission of the American Diabetes Association. There are multiple ways to get involved. You can do so by volunteering time. Give your time and expertise. There are individual and group volunteer opportunities that are available through signing up on the ADA's website. Donate money. Contribute to ADA's ongoing processes and programs designed to drive impact. You can do one-time or recurring donations that also can be made through the ADA website or by mail. Commit to health equity. Get familiar with local ADA offices. Local ADA offices are great places to learn about community resources and upcoming events. Understand the ADA's Health Equity Bill of Rights. Partner with other organizations that access root causes of health disparities. And finally, we should all be advocates at an individual level, as a societal level, and organizational level. We need to advocate very strategically, intentionally, and deliberately for systems change to address social determinants of health so that we can seek opportunities to facilitate a re-engineering of business models and care models towards achieving health equity delivery and accountability. Your support sustains ADA's very important work, it's critical work to prevent and cure diabetes, to stem the rise of type 2 diabetes, and to improve the lives of all people affected. I cannot reiterate this more, that it's an individual responsibility, it's an organizational responsibility, it's a community responsibility. Indeed, it is a societal responsibility. So I'll close with a number of quotes. A wise woman once said, "Do the best you can until you know better. And when you know better, do better." And that wise woman was Maya Angelou. Since 2002, we should have known better. Indeed, since COVID-19, we do know better. And after today, I hope we still even yet know better. So since we collectively know better, we should become force multipliers so that we can help the ADA to do better. There comes a point when we need to stop just pulling people out of the river downstream. We need to go upstream to find out why they are falling in. And this was Archbishop Desmond Tutu, the late Archbishop in South Africa. And he was talking about upstream drivers and downstream impacts, social equity, very applicable to any vulnerable society. So we need to go upstream to find out why people are falling in. We need to look in the mirror and confront the elephant in the room. And finally, quote from a revered civil rights leader. And in the presence of his and his fellow followers campaign for racial equity in America, they suffered water hosing multiple times. And he said that there was the fact that there was a certain kind of fire that no water could put out. And he went on to say that there's a certain kind of fire that is different from the fire that preceded the civil rights movement. He went on to say that there was a kind of fire that could not be put out by water, a fire that belied the understanding of the physics they learned in school. And my take on that is that we must develop a collective fire that no societal water hosing, also known as an anti-woke agenda, can put out. I thank you again for your courtesies and for your invitation. Thank you very much.
Dr. Aluko, Yele, that was a fantastic presentation. I'm glad we've captured it. I'm glad we captured this video. I think it is illuminating, and I'm privileged that many people within the American diabetes community will have the opportunity to see your presentation again and again. I also want to acknowledge you. This presentation is reflective of why the American Diabetes Association is honoring you on Thursday evening in New York City at the Alexandria Life Sciences Center with its first Health Equity Award. I cannot think of anyone more deserving at this time than yourself. You have been a voice on these issues. You have been candid with the nation. You have brought forth data, both clinical and financial, but most importantly, you have really highlighted through the work that you do the human suffering that exists, not necessarily because we lack innovation, but perhaps because we lack compassion and commitment to make sure that the care available reaches those most in need. And often it's not just the medical care that they need. They need the obstacles broken down and pulled away in front of them. And of course, as individuals, we can do more to protect our health. We can eat better, we can exercise, but that in itself is a tall request for people who don't have sufficient funds to buy healthy food, for whom fast food might be considered an inexpensive option and actually contributing to their long-term health disparities. And I think you brought that out quite clearly in this presentation. I want to thank you for this. I'm looking forward to seeing you. We met during the beginning of the COVID period through our conversation with the pharmacy community. And I remember some of those comments quite clearly when we talked about the fact that whether it's intentional or unintentional, there sometimes is a built-in racial inequity that exists within the health system. You and your colleagues have done a tremendous amount to bring light and illuminate a path to better health, as the American Diabetes Association seeks to do. And I want to thank you so much for highlighting why it is important for people to volunteer and engage with the ADA in addressing many of the priorities you eloquently laid out in this presentation. I look forward to seeing you soon. I, again, on the behalf of the American Diabetes Association community, want to recognize you and thank you for your work in improving people's health throughout the United States. Thank you, Yele.
Thank you, Gil, and thank you for your leadership, and thank you, ADA.
We'll see you soon. And again, Dr. Aluko is available to answer all questions. It is now 1 o'clock, but all the same, if you have questions, please send them to us on this link or to me at gil.bash@finpartners.com. I will collect them. I will send them over to Dr. Aluko to answer personally. We thank you very much for joining us today. We encourage you to be involved with ADA activities in your community so that you can make a difference. Thank you all.